Hi everyone, my name is Dr. Babawale, and I'm welcoming all of us to the beginning of the multi-system component of our Step 2 CK, and we'll be starting our discussion by talking about shock. So we are not going to waste much time here because I know we are very familiar with the concept of shock and what it entails from our Step 1. So um, shock is just defined as a condition where you have a reduction in the effective circulatory blood volume, leading to um, tissue hypoxia and a compromise of the organ function. That's it. Anything that can bring about a drop in the tissue level oxygenation and an eventual dysfunction of the organ. That's basically shock. And we need to look at the different types, their causes and physiology parameters, which we can measure to distinguish them and our approach to treating them. So I know we are already familiar with the four classes of shock: the hypovolemic, the cardiogenic, the obstructive, and the distributive shock. We know what to look out for with respect to the cardiovascular parameters, and we have an idea of the common causes. So talking about the parameters, we basically, ideally, we should be looking at about five of them. Um, the cardiac output, just like we have here, the pulmonary capillary wedge pressure. So the pulmonary capillary wedge pressure is just a big name for the pressure within the pulmonary venous circulation and an extrapolation of the left atrial pressure. So what they are just trying to to say here is that they are wedging the pulmonary capillary. So when you wedge something, you kind of obstruct it. So they put more like a balloon within the pulmonary capillary, and the pressure beyond that balloon is being measured. So we know that what empties um what is after the pulmonary capillary is the pulmonary vein, right? So anything beyond that wedge area is going to be giving us an idea of the pressure in the pulmonary vein. So the higher the left atrial pressure, the higher the pressure within the pulmonary vein. So that is talking about the pulmonary capillary wedge pressure. Then the peripheral vascular resistance or the systemic vascular resistance. Um, we are also supposed to talk about because we have talked about the pulmonary capillary wedge pressure, which is a pressure on the left side of the heart. We are also supposed to have a parameter that defines the pressure within the right side of the heart, which should be the central venous pressure. But don't be confused. The question might not put central venous pressure there. They might put the jugular venous pressure. So, because the jugular vein is a central vein, so it can be a representation of the central venous pressure. And of course, the approach or the modality of treatment. So let's take them one by one and we discuss their causes, what they look like with respect to the physiology parameters and how we are going to go about treating them. So the first is hypovolemic shock. Hypo, low, volemic, volume, low blood volume. That's what it means. So anything that can bring about a reduction in the blood volume brings about hypovolemic shock. So this can be caused by trauma. So anybody that experienced trauma might be from a fracture injury. The excessive blood loss from there can cause hypovolemic shock. Somebody that is experiencing frequent protracted vomiting and diarrhea, they are losing a lot of fluid and they'll become dehydrated, and at the end of the day they can get um, deteriorated to hypovolemic shock. People with thought space loss. So, yeah, for example, an individual with intestinal obstruction, you can have a lot of fluid pulling up upwards or just proximal to that obstructed region. A lot of fluid secretions and the likes. That's a form of thought space loss. Is going to bring about hypovolemic shock because it is going to reduce the effective circulatory blood volume, because effective circulatory blood volume is the amount of blood that is within the intravascular. So we are not even talking about the one that are extravascular or within the thought space. We are talking about the one that is intravascular, because that is the one that is going to get delivered to the tissues. So thought spacing, like in intestinal obstruction, will eventually definitely lead to hypovolemic shock. Bone injury. Bones injury can bring about, plasma loss, loss of extracellular fluid volume. That will bring about volume loss and eventual hypovolemic shock. So what are the changes that we expect? This is already what we know. Very easy. When there is a reduction in the blood volume from hypovolemic shock, you don't even have enough blood that is going to return to the left and the right side of the heart, right? So it makes sense for us to see a drop in the PCWP and a drop in the central venous pressure or the jugular venous pressure, because you don't have any blood. You have little blood returning to the right and the left side, right? So because of little blood returning to the right and left side, the cardiac output, which is the amount of blood that is being pumped out from the ventricles per beat, that is stroke volume, that is being pumped out of the ventricles, is reduced. So that's our cardiac output. So that is also expected in hypovolemic shock. And what is going to be the response of the autonomic nervous system to this? Because when there's a drop in the cardiac output, there is likely going to be a drop in the blood pressure, because blood pressure is a product of the cardiac output and the what? The peripheral vascular resistance. So if the cardiac output is reducing and the blood pressure is reducing, the autonomic nervous system will try to restore homeostasis by trying to bring up the peripheral vascular resistance by activating the sympathetic nervous system. So that is more like a compensatory response. So the PVR increases. The PVR increases. So we have discussed about 4 parameters now. We have talked about the cardiac output that will drop in hypovolemic because you have little blood returning to the right and left side of the heart, and hence, because of little blood returning to the right side of the heart, there's a drop in the central venous pressure or the jugular venous pressure. Because of little blood returning to the left side, there's a drop in the pulmonary capillary wedge pressure. Because of the drop in the cardiac output and an eventual drop in the blood pressure, there's a rise in the systemic vascular resistance to cause vasoconstriction so that you can have high BP. But that does not work. It does not actually raise the blood pressure. It's just more like a compensatory mechanism, which has little or no effect until you correct the underlying cause of the pathology. Then lastly, there's another vital parameter that is not included, and that is the SVO2. The SVO2, the SVO2, the SVO2 is talking about the mixed venous oxygen saturation. So the way I just want us to look at that so that we don't get things complicated in our head is just to assume that once there's a drop in the cardiac output, your mixed venous oxygen saturation is going to drop because it is blood that carries oxygen. So just look at it like that. When there's reduced cardiac output, that means that you are not pumping enough, blood or fluid through the tissue. So they will have little or no oxygen to extract. So basically, the mean venous oxygen concentration. Why am I saying mean? The mixed venous oxygen concentration saturation will drop. Yeah. But if there is a situation of increased cardiac output, the mixed venous oxygen concentration is going to be increased because you have a lot of fluid being pumped to the tissues. That is going to deliver more oxygen. And because of the fact that the cardiac output is increased, there's a tendency for a fast transit of the blood across the tissue. So they might not even have time to take out a lot of oxygen for their own metabolic use. So the amount of oxygen in the venous blood that is returning back to the heart is likely going to be increased. So that's just a very simple way to get the concept without stressing our brain. Because if we want to go in detail into the explaining part, it might, get so tiring and everybody will just get confused. So easy way, low cardiac output, low, SVO2 or MVO2, oxygen concentration within the venous um, component of the circulatory system. High cardiac output, high SVO2 or MVO2, anyone you see in the question. So, because here in hypovolemic shock, this individual is not having adequate cardiac output, so we expect the MVO2 to reduce. So, how do we treat an individual with hypovolemic shock? So, we treat according to the problem. So, because most of them will come in a state of shock, somebody with trauma, they bled a lot, somebody that have vomited tirelessly, person has lost a lot of blood fluid, so body fluid. So you need to replace that, right? And you need to give a fluid that is physiologic, so a fluid that has almost similar component as plasma, so that you don't cause any um, hemodynamic shift, right? You don't want fluid, electrolyte, everything to be moving up and down. You want to give something that is identical to plasma, isotonic solution. So, like Ringer's lactate or normal saline. So, most of the time, pick Ringer's lactate. You know, Ringer's has everything. So, you have your lactate, you have your chloride, have your what's it called? Sodium, everything, physiology concentration, right? Um, to resuscitate that person at the initial phase, then later, if this person came in, due to trauma, you have to give blood after the initial stabilization. Very, very important. And you make sure that um, you don't continue to give crystalloids, your ringers, lactate, your normal saline, beyond 2 liters. So once you give 2 liters to stabilize, you need to get blood to resuscitate that person. Very, very important. Very, very important in the situation of blood transfusion. So that's that about hypovolemic shock, depending on the cause. So if somebody experienced trauma and the person is bleeding or blood, you need to give blood. Although you might give your physiologic fluid like your crystalloids, your ringers at the initial phase, but you need to give blood transfusion later. But somebody that comes in due to dehydration from vomiting, from diarrhea, or from IO, intestinal obstruction, you just need to give your isotonic fluid. So you don't need to worry about looking for blood transfusion in that situation. So you treat according to the etiology. Then the next is cardiogenic shock. So here we are just having problems, impeding on the cardiogenic effects. So the heart cannot contract adequately to move our blood into the systemic circulation. So this can come from myriads of causes. Maybe there is a myocardial infarction that is impeding on the ability of the heart to contract, or there is an arrhythmia that is causing irregularity in the electrical system, and the coordination of the heart to contract is not there. For example, an individual with ventricular fibrillation, they cannot generate a regular rhythm to facilitate heart contraction. So there will be no cardiac output. Or an individual with heart failure, they are going to experience cardiogenic shock. Structural heart disease like cardiomyopathy, like mitral regurgitation, I want to say. I want to see what's on the screen here. So, you know, they can experience cardiogenic shock because um, we are having constant regurgitation of fluid from the left ventricle into the left atrium. So something that's supposed to be going forward to the aorta is going backwards, into the left atrium, into the pulmonary vein. That is not helping, right? So most of the time, the causes of cardiogenic shock are usually left-sided. So if you look at our step one, you will see there that the pathophysiology for cardiogenic shock is stated there as left ventricular dysfunction. Yeah. So, but you know that when there's left ventricular dysfunction and you're having pulling of blood back into the left atrium, then back into the pulmonary circulation, it will definitely go back to the right side. And from the right side, right ventricle right atrium back to the systemic veins. The JVP is going to be elevated. So that is one thing I want us to have at the back of our mind. In cardiogenic shock, you typically, most of the time, you are going to notice elevation of both the right side pressures and the left side pressure. So there's going to be elevation of the PCWP and the CVP in cardiogenic shock, as opposed to what we have in hypovolemic shock, where there's a drop in the CVP and a drop in the PCWP, because you have lost all the blood that's supposed to return to this section of the heart. But in cardiogenic, you cannot even push it forward. So that means they'll be going backwards. So causing elevation of JVP, elevation of PCWP in the left side. So what is going to happen to the cardiac output? Cardiac output is going to drop, because when you cannot push something forward, it's going backwards. And forward is talking about the cardiac output, the one you are moving out to the tissues, right? So cardiac output drops. So the cycle starts all over again. The blood pressure drops. The autonomic nervous system tries to restore homeostasis by increasing the systemic vascular resistance after activating sympathetic firing, right? SVR goes up, right? So what happens to the SVO2? The mixed venous oxygen saturation. We have said cardiac output drops, so that means that MVO2 will sensically drop. That is it. So you treat the underlying cause of the cardiogenic shock. So what is causing it? If it's an arrhythmia, treat the arrhythmia, give antiarrhythmics if you need. Um, Synchronize cardiovascular. Do that. If you need to defibrillate, do that. Heart failure, you give your diuretics. There's any tropes, you give it. People with VSD. So yeah, VSD can be a cause of cardiogenic shock, because here you are supposed to have blood moving from the left ventricle ideally into the aorta, but in VSD you're having a left to right shunting. So the blood that is supposed to move from the left ventricle into the aorta is going through the right ventricle. That doesn't make sense. So cardiac output is definitely going to reduce. And when you have a lot of blood pooling within that left ventricle, they might go back. Some of them can even go back to the left atrium, causing elevation of the PCWP. And you have also a lot moving to the right ventricle. They can also travel back, to the IJV, causing elevation of the jugular venous pressure or the CVP. That's the way it works. So don't forget, elevation of both PCWP and CVP is seen in cardiogenic shock. So treat the underlying cause, like we have said. And most of the time, you might want to give the person inotropic support, because you want to maintain that contractility of the heart so that you can push it forward instead of backward. So inotropics, like you giving dobutamine, that's one of the best. Substitution, you might consider dopamine or mirinone. So, and in some individuals, we might assist them by giving them intra-aortic balloon pump. So put a pump at the descending part of the aorta, just distal to the left subclavian vein. If you remember our anatomy very well, and you inflate and deflate the pump. So once you deflate the pump, that means you are reducing the afterload, right? Sorry, when you inflate the pump, so you are kind of widening the aorta, and you are reducing the afterload, so that you are creating more space, for the heart to easily pump blood into um the aorta. Then you deflate at diastole, increasing the diastolic pressure, so that you can have more blood flow to the coronary vessels that supplies the heart, so that the heart will be more gingered. So that's the mechanism of the intra-aortic balloon pump. In some situations, you might need something even more advanced than intra-aortic balloon pump, like you're talking about the ECMO machine, which I know Dr. Babarinde is going to trash when we get to the cardiovascular section. So we should watch out for that. Although it's very good to pay attention to the basic stuff, but you never can tell, because technology, advances in medicine. So we need to be familiar with all these systems as well. Obstructive shock. Yeah. So here there is a form of obstruction, either to um, fill in or emptying. There is an obstruction within the heart. I'm going to, pause a little while here, because we need to know that we have many reasons for obstructive shock, but I see it as two major categories, Group A and Group B. And what is in Group A? Group A, cardiac tamponade. Group B, others. Cardiac tamponade is different from all of them. Cardiac tamponade is different from all of them. Yeah, they are all causes of obstructive shock, but the presentation of the parameters for cardiogenic shock for cardiac tamponade is different from what you see in P, different from what you see in tension pneumothorax. So we already know what happens in cardiac tamponade. You just have a massive pleural effusion with fluid accumulating within the pericardiac sac, compressing on the heart. So when these tamponades are compressed on the heart muscle or the heart tissue itself, the heart will find it very, very difficult to relax when it comes to diastole. So that means there's going to be an obstruction to diastolic feeling. Yeah, that's the way it works. So, but what we need to always remember with respect to cardiac tamponade that you might typically see in question is the fact that there's going to be an equal distribution of the diastolic pressure across the four chambers of the heart. That makes a lot of sense because the fluid is accumulating within the pericardial space. And we remember that the pericardium surrounds the entire four chambers. So that means that that pressure is going to be distributed to all the chambers in as much as they are covered by the pericardium. So what you are going to see in question that is going to raise suspicion for that is that you notice that in the right atrium, you are seeing 40/20. In the left atrium, you are seeing 50/20. In the right ventricle, you are seeing 60 or 70/20. In the left ventricle, you are seeing 100/20. You know that is the constant diastolic pressure that is elevated. It's 20 millimeter of mercury. So that's equalization of pressures within the cardiac chamber. That is classic for cardiac tamponade. And another echocardiographic finding that we see in individual cardiac tamponade is what? Plectoral of the IVC. So, because of the obstruction through the filling, we are going to have a lot of fluid pulling in the IVC, which is taking blood from the lower extremities back into the heart. So you see that the IVC is going to massively pull with blood and plethoric. So once you see that in question, think about cardiac tamponade. Think about cardiac tamponade. IVC plectoral equalization of the pressure. So they like keep it simple. They will just give you values. So it's now left for us to now think about the values. What are these cardiac catheterization pressure telling me? There's a uniform distribution of diastolic pressure, keeping constant throughout. It tells me there's likely to be a cardiac tamponade going on. So because of the fact that all the chambers are affected, so what is going to happen to the pressures? So at diastole, the right side cannot empty, the left side cannot empty. So that means that you are going to have downstream elevation of all the pressures in the right and the left side upstream. So that means that because right atrium cannot relax, left atrium cannot relax, they cannot move their blood, feel adequately and receive blood from their corresponding vessel that is supplying them. Meaning um, the systemic veins, the internal jugular vein, the superior vena cava, the inferior vena cava, they cannot empty directly, into into the right atrium. The right atrium cannot relax to receive it. So it means that blood is going to be pulling upstream into these vessels. So the central venous pressure is going to be elevated. The left atrium cannot relax adequately to receive blood, from the pulmonary veins. So the pulmonary capillary wedge pressure is going to be elevated, right? So that is what we see in cardiac tamponade. And because of this failure of relaxation in diastole, you don't have enough ventricular filling, right? Cardiac output is going to drop. The reflex mechanism is going to kick in. The systemic vascular resistance is going to go up. MVO2 is going to go down too because of a drop in the cardiac output. So don't forget, presentation for cardiac tamponade is very similar to cardiogenic shock, and you just have to remember the Beck's triad to quickly knock out your cardiac tamponade, your muffled out sound, your JVP, and your hypotension. You just quickly knock it off, and you do a pericardial cardiocentesis, a pericardiocentesis to treat the cardiac tamponade. The other causes for obstructive shock, individuals with massive pulmonary embolism. Massive pulmonary embolism, you have a clot occluding the pulmonary trunk. So I'm not going to go deep because we have talked about this in the respiratory section, so we already know it very well. And you just have more like an increased afterload to the right ventricle. So right ventricle is finding it very difficult to pump into the pulmonary trunk, and everything will start going backwards to the right atrium to the JVP, causing elevation of the JVP or the central venous pressure. Shaking now is not affecting the left side, so the pressure in the left side drops, right? The PCWP drops because all the fluid is pulling to the right side, back, downstream to the organs, to the legs, to the liver, to the stomach, everything. They are not finding their way back to the left side. So the PCWP drops, the cardiac output drops, the PVR or the systemic vascular resistance increases, and the oxygen, saturation within the veins, the MVO2, SVO2 also drops. So what do we do to treat the PE we have to give? Because this is a massive PE. We have to give our thrombolytics, Hot base to lyse that clot and relieve the patient, thrombolyze. So we also have to remember the other clinical, the right bundle branch block, the right ventricular strain, and all those things that we are going to see in the question stem that is going to raise suspicion for pulmonary embolism. Of course, we are going to get the sudden onset symptom. Very important. Everything is always sudden onset. Sudden onset chest pain, sudden onset dyspnea, sudden onset difficulty in breathing. They might put it there to help us that the patient had already had history of leg swelling to, give a clean chart that the person has a DVT, and suddenly the person had maybe long flights, and afterward the person could not breathe again, with massive chest pain. And suddenly they check the vitals, this person is already hypotensive. You think about a massive pulmonary embolism and you want to immediately thrombolyze. Tension pneumothorax. So there is anything, maybe the person was placed on a mechanical ventilator, or the person has a chest injury from maybe a stab, and um, there is creation of a one-way valve within the pleural cavity surrounding the lungs. So you have air filling into that pleural cavity, the pleural sac, and when the air gets so big, it's going to compress on the lungs. And when it compresses on the lungs, it's going to shift the lung to the contralateral side. So that will bring about a mediastinal shift. And remember that part of the structures we have in the mediastinum includes the vessels like the IVC, the SVC. So the IVC becomes kinked, becomes constricted. So it means it will not be able to empty into the right side of the heart. So that means you have a lot of blood pooling in the IVC, causing a elevation of the JVP or the central venous pressure. Very easy. Another way to look at it is when there is tension in motorized and you have a one-way effect in which you're having a lot of air entering into the pleural cavity through that opening in the lungs from the stab injury. And but air cannot escape. So air is entering in inspiration, but air cannot get out in expiration. So, and that is ballooning out the pleural cavity. It's filling up the pleural cavity. And we know that the pleural cavity is just a space within the viscera and the parietal layers that surround the lung. So that means that they can easily compress on the lung. So just imagine, um, um, you know, um, you have a, something covering the lungs, and that cover is now getting filled with air. It's going to compress on the lungs, and it's going to push it away. So that is exactly what's happening in tension pneumothorax. And when that happens, we know that there's going to be an increase in the intrathoracic pressure. And we know that the intrathoracic pressure is always transmitted to the pulmonary vasculature. So when there's an increased resistance within the pulmonary vasculature, what happens to the right ventricular contraction? The right ventricle is going to find it very difficult to pump blood into the pulmonary vasculature. So that means that the blood is going to be going backwards to the right atrium, then backwards to the central venous system, leading to increased central venous pressure or GVP. So what do we do? Because this is a case of tension in pneumothorax. There's tracheal shift, there's mediastinal shift. We have to do a needle decompression. So don't forget, this is tension. If it's not tension, just a large pneumothorax, you don't need to do any needle. Just put your chest tube. But if it's tension, you needle, then you put your chest tube later. Very important stuff to remember. Please never get carried away. You are going to see it in your question like that, like that. The last part is the distributive shock. So what happens in distributive shock? Majority of the causes of distributive shock, they are all associated with a compromise of the venous tone. So there is veno or vasodilation. So there's dilatation of the vessels, they are dilated. So, and we have three, a lot of causes of distributive shock. And just know that all of them, they bring about vasodilation. And when there's vasodilation, there's going to be increased cardiac output, because when you vasodilate, you have dropped the afterload. The afterload has been reduced. So that means that the heart is now relieved. So I can now contract and move blood into the vessels, right? So cardiac output increases in distributive shock, except one form, and that is neurogenic shock. The cardiac output will not increase in neurogenic shock. Why? Because in neurogenic shock, there's a damage to the sympathetic trunks. So when the sympathetic nerves are damaged, it means that all sympathetic effect is lost. Sympathetic effect brings about vasoconstriction. So that means that there's going to be vasodilation when there's neurogenic shock. Sympathetic activity controls cardiac contraction. So it means that once there is damage to the sympathetic trunks, you cannot contract the heart again to achieve cardiac output. So it makes sense for cardiac output to reduce in neurogenic shock. In septic shock, cardiac output is increased because you have vasodilation reducing the afterload, fine, but there's no compromise of cardiac contraction. So the heart can still contract in the early phase and easily move blood into the systemic circulation because you have reduced the afterload. But when it gets to the late stage, when the cytokine effect overwhelms the heart will eventually fail. And there's going to be a drop in the cardiac output. That's what I want us to keep in mind. But most of the questions then will not really tilt it towards the late phase of septic shock. So they are going to keep it at the early phase where you are going to be having a drop in the systemic vascular resistance, causing vasodilation and increased cardiac output. So don't forget, you can see the arrows here for systemic for septic shock. There is an increase in the cardiac output, very, very important. And there is a drop in the PCR. The peripheral vascular resistance reduces, right? Very, very important. Very, very important. And so because of the peripheral vascular resistance reducing and there's vasodilation, the veins are going to accommodate a lot of the blood volume. The veins have high capacitance. That means they have high capacity to hold blood, and they will not readily return it back to the heart unless they are subjected to vasoconstriction. But you don't have venous constriction in somebody with distributive shock. It's gone. So that means that all the blood that is being pumped down into the tissues, into the system, is going to accumulate within the vein, and you are going to have reduced venous return. So when there's reduced venous return, what happens to PCWP? PCWP drops. What happens to CVP? CVP drops. Very easy. So, what is the cause of septic shock? Infection. That's septic shock. Infection. So, any infection, gram negatives, basically, most of the time they can cause septic shock. And what do? You have to give them enough antibiotics, IV, enough fluid, aggressive fluid resuscitation, using about 30 ml per kg of the body weight with enough broad spectrum antibiotics. After you have taking your culture to know the right antibiotics to give. Some people might actually need vasopressor support, because for you to even call it septic shock, it means that that individual needs vasopressor to keep the mean arterial pressure beyond 65 millimeter of mercury, and the lactate level is more than 2 millimole per liter. So I'm not trying to confuse us. We are going to get there, and we'll discuss it more. So, um, so people with septic shock tend to have massive hypotension, you know, and because of a drop in the systemic vascular resistance, and you might need to give vasopressor to increase the blood pressure. So you need to give your antibiotics, but you need to obtain your blood cultures fast before giving your antibiotics. So anaphylactic shock is very similar to septic shock. They have the same parameter changes. But the etiology is just the difference. Anaphylactic shock comes from people that get exposed to bee sting, use some particular medications, or eat some certain food. They may become allergic to those food and they don't know. So, and when they take those food, they become, you know, they will have been sensitized, and they just have that allergic episodes, and they start presenting with angioedema, facial swelling, wheezing, hypotension, urticaria, and all those things. So once you see that in the question stem, somebody gets exposed to bee sting or use some medication and suddenly become hypotensive with rash, wheezing, bronchospasm, think about anaphylactic shock, because those guys have type 1 hypersensitivity, release of cytokines like histamine, leukotrienes, and all those things from the mast cells and the basophil. So, and you know, they can drive um, an anaphylactic shock because they have a very potent vasodilatory action on the vessels. So everything will now, you know, starts happening just like the way we have discussed. The vasodilation is going to bring about a drop in the blood pressure, is going to bring about a drop in the afterload, cardiac output is going to increase, but at the same time, the veins are going to accommodate a lot of volume, reducing the amount of blood that returns to the heart. So CVP, PCWP drops, right? And what do you do to treat anaphylactic shock? What do you do to treat anaphylactic shock? You have to give them epinephrine. So epinephrine is best bet to treat anaphylactic shock, but what we just need to be careful about here is the route of administration. So you want to give IM. So IM is faster, very fast. You know, you can easily give it without needing to be set in line IV, and then you know you can give a moderate dose. You know, preventing the cardiac side effect of epinephrine. So, compared to the IV that you might, excessively push too much, which can, lead to some complications. So, IM is the preferred initial approach to treating anaphylactic shock by using epinephrine. So, the epinephrine will help vasoconstrict the vessel. You remember the major problem in anaphylactic shock is vasodilation. So, you vasoconstrict, trying to reverse the changes, and the epinephrine will also kind of reduce the release of those inflammatory mediators, the histamine from the mast cells, so reducing, the cause of the inflammatory trigger having issue. And because we know that part of the implicating cytokine is histamine, you can give antihistamines as adjuncts and steroid to reduce the inflammatory response. Shikina. Then we also have the systemic inflammatory response syndrome, which we are going to talk about properly, right? So this is just more like some inflammatory response. That's the word, to infectious or non-infectious, you know, insult. So it involves four criteria. So you just need two to be positive. So the SRS comprised of four criteria. I'm not sure I have it here. That's a very big mission, but I know we are familiar with it. The first one is talking about the temperature. So the temperature might be greater than 38 or less than 36. So somebody can have infection, let's say E. coli, So part of the systemic inflammatory response is what? Either hypothermia. No, I don't want to say hypothermia. So let's just say increase in the increase in body temperature or a decrease in body temperature. So you can have a body temperature increasing 38 degrees Celsius beyond, or reducing 36 pressure 36 degree centigrade beneath. Right, any one of them qualifies for temperature. Then another one is the respiratory rate. So uh, the the respiratory rate might be more than 20 cycles per minute, or the partial pressure of CO2 might be less than 3.2 kilopascal because they will have increased respiratory rate, right? Respiratory rate increases. So they try to breathe more. And when you breathe more, respiratory rate fires greater than 20. And you know that when we breathe more, we tend to bring out a lot of CO2. So that means that there's a tendency for CO2 level to come down. So that's why we say PCO2 less than 3.2 kilopascal. Then after the respiratory rate, we look at the heart rate. So the heart rate might be more than 90 beats per minute. And then lastly, the leukocyte count. So you can have leukocytosis of white blood cell count of 12,000 or less than 4,000. Or we have burnt from more than 10%. So once we have more than 10% burnt from, or we have a white blood cell count more than 12,000 or less than 4,000, that is the white blood cell changes that is accepted. So any two of these, qualifies for systemic inflammatory response syndrome. So when you have any two of these with infection, right? That is sepsis. That is sepsis. Any two of these with an infectious focus, sepsis. So any two of these, but non-infectious. So maybe somebody has pancreatitis or they have bone injury, they have trauma, they can also develop systemic inflammatory response syndrome. But in that situation, it's not going to be called sepsis because it's not from an infection. So, but don't forget what is connecting all of them is the cytokines that is causing all these inflammatory response changes. Your TNF alpha, your interleukin 1, that's what is bringing about fever. Do we get? So cytokines is what is causing everything, right? So those cytokines play major role in causing distributive shock. So somebody can still have distributive shock from pancreatitis, from burns, from trauma because those cytokines can have a vasodilatory effect on the vessels, and all those things that we have been saying will start happening. So you have to manage the underlying cause. Then the last is a neurogenic. So neurogenic is what I like because it's kind of a little bit different from there. It's a little bit different. So please, we should not fall into that trap. I don't like it because it's kind of easy to kind of miss, but please always watch out for neurogenic shock. So somebody that has a brain injury, a spinal cord injury, and the person is having vasodilation because of the cutout of the sympathetic chain. But you notice that the cardiac output is going to be low, so they can give us the arrow in our exam. Pick low cardiac output because the sympathetic nervous system component is gone and you cannot adequately pump blood again, even despite the drop in the afterload from the vasodilation. The cardiac activity is not sufficient to pump blood even against that reduced cardiac output. So cardiac output, even against the reduction in the afterload, that's what I mean. Let me take that again. So in neurogenic shock, the patient has a brain injury, a spinal cord injury, damaging the sympathetic nervous system, and there is, vasodilation. You have dropped the afterload. So what should happen ideally is that the heart should be able to contract to pump blood against that reduced afterload. But you remember that sympathetic control is also in charge of cardiac contractility. So it means that there's no sympathetic activity to even facilitate that cardiac contraction. So the heart will be weak too. So cardiac output will drop. So cardiac output drops in cardiogenic shock. And then we remember that after cardiac output drops, there's always a reflex, which includes increase in the systemic vascular resistance, increase in the heart rate. So it is only in neurogenic shock that there is bradycardia. There's no tachycardia. In most of the other ones, the septic shock, the cardiogenic, you are going to have increase in the heart rate. Yeah, there's going to be a reflex tachycardia. But here, there's bradycardia. So once you say bradycardia, cardiac output drop, vasodilation, you know, hypotension, think about neurogenic shock. Think about neurogenic shock. Always think about neurogenic shock. Please think about neurogenic shock. Okay. So the first vital sign to change in hemorrhagic shock is the and before I go, I also need to talk about the fact that everything except the distributive shock, they usually have a cold clammy skin. There's no there's no need to get confused. When there's a drop in the cardiac output, there's going to be cold clammy skin because the extremities, the tissues, the legs, they are not getting enough blood from the low cardiac output. But in distributive shock, there is no cold clammy skin. It is warm because cardiac output is high. Cardiac output is high. So once you say warm extremities, don't think, that person is doing well. It is due to the vasodilatory effects and high cardiac output from the distributive shock. Please, very, very important. Warm extremities is peculiar to distributive shock. Cold, clammy skin is peculiar to the other forms. So once somebody starts bleeding, the first changes is the heart rate increase, even before the blood pressure drops. Please, don't forget. Then you start seeing changes in blood pressure when the person has lost about 30 to 40% of blood volume. So that's when you start seeing blood pressure change. So reflex tachycardia is always the first. First tachycardia is always the first. So moving on to fever, the post-operative fever. So post-operative fever is just talking about fever, elevated temperature that happens temperature that happens following surgery. That's what I mean. So, what I just want to say here is that we should not think of an infectious cause before 3 days post-op, please. Because you need time for the infection to develop, to replicate, to multiply, to release the cytokine and cause the fever. So it doesn't happen before 3 days. So, it's being classified into 5 major categories based on the timing of the fever. So the USMLE like asking this a lot of the time. So based on the timing, you have some causes of post-operative fever that they can cause the fever at any time. At any time. So, but we are going to get clinchers in the question stem that is going to tilt your mind towards any of those pathologies. So 3 things majorly comes to mind: drug reaction. So people that have used antibiotics, anti-epileptics, antidepressants, they can trigger drug reaction that can lead to fever. Then commonly malignant hypothermia. So the person, is being scheduled for surgery and they want to do maybe a form of general anesthesia and they give the person volatile anesthetics like sevoflurane, desflurane, isoflurane, except nitric oxide. Please don't fall victim. Or the person just was given succinylcholine for paralysis. That can trigger malignant hyperthermia. So malignant hyperthermia is a genetic condition in a way. It occurs usually when there is a mutation within the ryanodine receptors, right? It can be genetically transferred in some people, while in some other condition, people it might be an acquired condition, but most is related to, a genetic problem in the gene coding for that ryanodine receptor. So there's massive release of calcium, skeletal muscle contraction, hypermetabolism, increased generation of CO2, increased oxygen demand, lactic acidosis, and the likes. And of course, most importantly, muscle rigidity from the contraction. So don't forget malignant hyperthermia. I know we have done it in our psychiatry section, and it should stay with us. Antibiotics, some antibiotics can also trigger um uh what's it called? Postoperative fever. So everything is under drug reaction. Antibiotics, anti-epileptics, antidepressants, even the volatile agent that we have talked about for malignant hyperthermia, all of them are under drug reaction. So um they can bring about postoperative fever, but it's not very common. Then the last one is the blood product transfusion reaction. The blood product transfusion reaction. So this is also known as the febrile non-hemolytic blood transfusion reaction. So it means there's no hemolysis but there's fever. It usually occurs within 1 to 6 hours following transfusion. And what is happening here is that when blood has been stored for too long, you tend to have release of cytokines from those leukocytes in that blood. So once the blood is transfused to the recipient, the cytokines are going to be released, and they will bring about a fever. Your TNF1, your interleukin 1, all of them can trigger fever. So that's how it happens. So that's why what you want to do is to do a leuko reduction before you transfuse, particularly when the blood has stayed for a long time. It's very common in children, and the question stem is just going to paint a child that develops fever, or any individual. It's just that it's common in children. They develop fever, chills, headache, you know, within 6 hours following transfusion. There's no sign of hemolysis. That is, you know, um, blood product transfusion reaction. So all of them are kind of like drug reaction in a way. So don't forget malignant hyperthermia, antibiotics, and blood products. So it's very common with antibiotics, though. That's why antibiotics is mentioned. Other drugs can cause it, but it's very common with antibiotics. So malignant hyperthermia, the drugs related to malignant hyperthermia, like those anesthetics, volatile ones, antibiotics, and blood products. So those are the wonder drugs, because the mnemonics is the W's. The W. So moving on to post-operative day 1 to 3. So we have talked about anytime. Anytime is the drug reactions, antibiotics, malignant hyperthermia, blood transfusion products. Then day 1 to 3. So the way I put it in my head is just to think about the modes of transportation. So we have wind, we have water, we have leg. So wind is like traveling by air, aeroplane, helicopter, jet. It's faster than water, ship, boat, you know, submarine. Why that one is faster than walking? So that's the way it moves. So the 1 to 3, you get there faster in a short time because you are moving by wind, right? Then the 3 to 4, water. 4 to 5, walking. Then 7 beyond, wound. So when it comes to the fever occurring between day 1 to 3, you might want to think about atelectasis or pneumonia. But if it's happening on day 3, then that's when you think about pneumonia. Please, if it's 1 to 2, don't think about pneumonia because that's infection, right? And we have said that infection doesn't develop until the 3 afterwards. So, but between the 1 and 3, think about wind. That is atelectasis or pneumonia. Atelectasis, lung collapse, lung collapse, lung collapse, pneumonia, lung parenchymal infection. So what are your prevention strategies? For atelectasis, you want to give incentive spirometry. So this is part of um, lung expansion strategies. But before I go to incentive spirometry, it's very important for me to mention that one effective way to reduce atelectasis is to maintain adequate analgesia, because following post-op, majority of them are in pain. They cannot breathe very well, particularly following chest surgery. So you notice that the patient will not want to breathe so that the person doesn't inflict too much pain. So that can reduce the amount of volume of air that gets in and out of the lung. So you tend to have easy lung collapse in that situation. You always want to promote increasing ventilation, like opening and closing of the lungs. That's what you want to do. So you maintain adequate analgesia. You encourage early ambulation. So studies have shown that early ambulation reduces the chance of atelectasis, either due to the fact that you are going to have sufficient excretory activity within the lungs when you ambulate, that can keep the lung open. And lastly, incentive spirometry. So it's part of those lung expansion strategy. You tell them to use one particular device that you call the spirometer, the incentive spirometer, which they blow air into very deeply and slowly. So they take very, you know, slow, deep breath in and out. That kind of keep the airway open and close, open, open, open. So preventing atelectasis. Then on the third day beyond, pneumonia. So day three, think about pneumonia. Antibiotics is the only way you can prevent pneumonia from happening. So encourage early antibiotics, you know, treatment. So um then we are done with the 1 to 3. Day 3 to 4, think about water, urine, UTIs. So the only way you can prevent your UTIs from causing postoperative fever is what? Don't use your folic catheter for more than a week. Remove it and change it after a week. Yeah, that is it. But if you retain it for a long time, it can cause fever within day 3 to day 4. So day 4 to day 5, you think about walking. So that means clot in the leg, right? DVT, PE, they can also be cause of postoperative fever. So the most effective strategy to prevent DVT is early ambulation. Please don't be deceived. Not heparin, not anticoagulation, but early ambulation. Those like, in atelectasis, it also helps to prevent DVT and eventual pulmonary embolism. Early ambulate, give anticoagulant like heparin, and the least effective, wearing TED stocking or compression stocks. Then the last is the site of operation. That's 7 days beyond, a week afterwards. Postoperative fever, a week afterwards, think about surgical site infection. So that's why you want to encourage frequent dressing so that you can promote fast healing and reduce chance of infection. And of course, pre-operative antibiotics to kill off any microbes that can contaminate that site. I know Dr. Barinde will have talked about endometritis very well as a cause of postoperative fever after seance section. So about maybe 2 days after the surgery, the patient can just develop fever, abdominal pain, tenderness, discharge from the vagina. So you want to consider endometritis as a possibility. And it's very common anytime between POD 2 and POD 10, but it's going to last for at least 2 days. Endometritis. So don't forget, you might want to do a CT scan to rule out your septic pelvic thrombophlebitis. So don't forget that. Very important for endometritis. And you might also want to place them on anticoagulant like low molecular weight heparin for about maybe 7 days, to reduce the chance of clot formation, particularly within the right ovarian vein. Very common. So that's all about endometritis. And we have talked about malignant hyperthermia. We have talked about the pathophysiology. We have talked about the presentation, the fever, the rigidity, the electrolyte derangement, because when the muscle is rigid and they are contracting massively, they will release myoglobin, they will release potassium. So there is hyperkalemia, right? There is increased metabolism in that muscle that generates a lot of CO2. So um, the 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 CO2 level is very high in the body, right? So hypercapnia is another thing you look out for. Then tachycardia, tachypnea again. So what you do is just you have to block the calcium channel receptor that is causing that hypercontraction by giving that toluene, and you want to do active cooling to reduce the temperature. fever of unknown origin. So fever of unknown origin, just fever of at least 38.3 degrees Celsius that lasts for 3 weeks and it's not diagnosed after 3 outpatient visits or after a week of hospitalization. That's just the simple definition for fever or no origin. Where's this fever coming from? Like, how can somebody have fever um of for 3 weeks consecutively and you know more than 38.3 after 3 outpatient visit or 1 week of hospitalization? I don't know the definitive cause. That is fever of unknown origin. So what I want us to pay attention to is that we have what we call MAIN. So MAIN is just the acronym for the cause of fever of unknown origin. Most of them are from infectious origin. So MAIN is talking about miscellaneous for hem, A for autoimmune, I for infection, N for the neoplastic. So majority of them are from infection, 60%. Autoimmune accounts for about 15, while in adults, rheumatic disease accounts for about 33% of the cases. So it's quite high. Rheumatic one is very high in older people, but generally infection is the major cause. So um, they present with fever, of course, but we don't know the cause of that fever. And that fever has been lingering like that more than 38.3 for more than 3 weeks. After 3 outpatient visit or after a week of hospital stay. So they can have other complaints like headache, malaria, and malaria. And the differential for this includes, you know, the infectious, the miscellaneous, the immunoplastic. So the way I just want us to look at it is just think about the infectious causes. Things are called like all this latent hidden infection. For example, tuberculosis. Endocarditis. All those things they hide. Endocarditis within the heart. You won't know tuberculosis. You know, some people might have occult abscess within the abdomen, within the prostate. They're just there. You don't know. And most of the things that cause fever of unknown origin, they kind of are very common in the healthcare setting. So when you think about the healthcare setting, you have to remember all these things I've listed here. Catheter infection, catheter infection. So people that are on urinary catheter, they can have fever of unknown origin. People that have NG2 inside too, they can have sinusitis. That can be a cause of fever of unknown origin. People that stay in the hospital for a long time and they are immobilized can develop DVT. So this will be under the miscellaneous cause, not infectious now. Then drugs. People that still under the healthcare related because when they go to the hospital, they might be placed on some certain medication and they can develop drug fever. That is also a cause of fever of unknown um, origin. And some people can also develop abscess in the healthcare setting. So abscess collection within the abdomen or the prostate, fever of unknown origin. So let's look at infectious ones again. Think about latent infection, the height, tuberculosis. Think about endocarditis. Think about people that are immunocompromised. Acronym is MHC. So M for Mycobacterium avium, A MHC. So H for histoplasmosis and C for cytomegalovirus. Then the other ones that we have mentioned for the healthcare related, which includes the catheter, people on NG2, people on catheter. So sinusitis, catheter related, and the other ones. Then the abscesses, right? Then for neoplastic, think about cancers generally. A lot of them. This list is exhaustive. Like it's a lot. Lymphomas, leukemias, hepatic cancer, renal cancer, multiple myeloma. There are a lot of cancers. It's not limited to this. A lot of them. So that means you have to do your investigation according to what you are seeing. Autoimmune. Autoimmune is a very, very common cause. Still disease is a very common cause. So still disease is just more like a inflammatory autoimmune disease that is characterized by three major signs. They are going to be having high fever, can be as high as 39 degrees Celsius. They are going to have a bumpy, non-puritic salmon pink rash. You know, they are going to have leukocytosis, right? And arthralgia. So you just get the three signs of fever, arthralgia of lasting for about 2 weeks, more. So it's minimum of 2 weeks. So they have to have arthralgia, arthritis for at least 2 weeks. They have fever and they have a bumpy salmon pink maculopapular rash with leukocytosis. So they can have some other systemic presentation like lymphadenopathy, like hepatosplenomegaly. But what I want to mention with respect to still disease is that there's some stuff that makes it different from SLE and rheumatoid arthritis. So because in still disease, the presentation is similar. You are seeing the arthritis, you are seeing the fever, hepatosplenomegaly, but the antibody markers are not positive. Like your ANA is negative, your rheumatoid factor is negative. So once you see a presentation of fever, arthritis, the pink macropapular rash with negative ANA rheumatoid factor, think about still disease. Think about still disease. Think about adult still disease. And they have a very high level of ferritin, and they are very responsive to steroids and interleukin 1 antagonists like anakira. SLE can be a cause. Rheumatoid arthritis can be a cause. Cryoglobulinemia can be a cause. So we know cryoglobulinemia tried of um, palpable, um, purpura, arthralgia, and fatigue. So they can tell you the patient is having a 3 month history of fatigue, tiredness, palpable purpuric rash somewhere in the part of the body with arthralgia. Think about cryoglobulinemia. They can help you further tell you that the patient has a history of hepatitis C infection. Makes life very easy for everybody. Polyarthritis nodosa, so one of those vasculitis that affect the middle size vessels. So there is a transmural inflammation there that is segmental and it affects almost all the organs except the lungs. So it spares the lungs. So it can affect the kidneys, they have hematuria, they have proteinuria, hypertension, it affects the brain, they can have stroke, it can affect the GI, they have abdominal pain, bleeding, melena, you know, um, can have the skin. They can have ulcers, they can have nodules, they can have levator reticularis. Dr. Brandy will talk about that in the rheumatology section. So, granulomatous is like sarcoidosis. We've discussed sarcoidosis so many times. We know what to look out for. Um, Miscellaneous causes. So, part of the miscellaneous causes is pulmonary embolism, DVT, just like we have mentioned under the healthcare related ones. So people with some DVTs, IBD, alcoholic hepatitis, drug fever, familiar Mediterranean fever, or facetious fever, can be the cause for the fever of unknown origin. So someone that has a DVT, P, someone that has been placed on some certain medication in the hospital, people with alcoholic hepatitis, people with facetious fever. So maybe the person is just faking it, just altering the thermometric measurement, just to get sick leave or something. Facetious fever. And in 10 to 15% of the cases, it is idiopathic. So I know the list is cumbersome. We don't need to actually, memorize all it. We just need to understand what we are working with. So the acronym is main. Just remember main, the miscellaneous, think about the autoimmune, think about the infectious and neoplastic. So for the neoplastic, it's a lot. It's a lot. So multiple myeloma, liver, kidney, blood cancers, neoplastic, infectious, think about the latent infection, tuberculosis, think about endocarditis, think about infection related to HIV, the MHC, avium, histoplasmosis, CMV, right? Think about abscess somewhere that's hiding. Think about abscess somewhere that is hiding. Is this person in the hospital? Is he on catheter, UTI? Is he on NG tube, sinusitis? Think about autoimmune disease. Common autoimmune disease we know, SLE, rheumatoid arthritis. We have added steel disease to it now, right? Polyarthritis nodosa, hyperglycemia, miscellaneous, most of them hospital related. Either the person has been immobilized for a long time, he has a DVT, but the person has been placed on some certain medication causing drug fever, you know, or the person is just faking it, factitious, you know. That's the way to look at it. Then you do your investigation accordingly to look for the underlying cause, right? You'll have gotten the history of that fever. Then you start taking your history in a detailed manner, right? You want to update the family history to know if this person has a familiar problem. Like, most of those autoimmune diseases they are familiar, right? You want to take a social history. Is this person drinking, alcoholic hepatitis, um, use of IV drugs causing endocarditis, right? Sexual history, HIV, because we've said it that MHC is a common cause. The Mycobacterium avium, the histoplasmosis, the CMV. Occupation. So where is this person working? Is he an healthcare worker? They can get exposed to. Does he work in nursing homes? Prison, they can get exposed to tuberculosis. It's a very common cause of fever of unknown origin. What is diet? What's the person eating? Yeah, because part of the cause is also typhoid fever, which is not mentioned here. So you want to know what the person is eating. Exposure to pet and animal. So part of also the causes includes things like brucellosis, Coxiella bonnetti. You know, they are also part of. I don't know why it is not saving. I kind of included it, but I think I lost it. So very important to know that things like okay, we are going to see it downwards. Brucellosis, Coxiella bonnetti, um, Bartonella and Selly. They are also common uh, Bato, Bartonella and Selly. They are very common causes of what's it called? Fever of unknown origin. So you want to get history of that exposure to cat and animals. Then travel history. You travel to Ohio, Mississippi, get exposed to histoplasmosis and the likes, right? So you start doing your lab work. So, it's a lot of stuff you can do. So it just depends on what you suspect. You can't do everything, right? Depends on what you suspect. So from your history, you know, and the way the patient is presenting, that's what is going to guide your labs. But you can do your complete blood count, you know, baseline. You can do your inflammatory workup, you know, panels like ESR, CRP, which is definitely going to be elevated in people with infection, people with some inflammatory disease like SLE and the likes. Your serum protein electrophoresis can help when you think of multiple myeloma. That's part of the malignancy. You want to do a multiple blood culture. Very important to make a diagnosis of somebody with endocarditis, somebody with osteomyelitis, right? Sputum gram stain and culture for tuberculosis. Your PPD for tuberculosis, acid fasting for tuberculosis, urinalysis and culture. We have said it that people that are on catheter, they can have um, fever of unknown origin in the healthcare setting. So you must do your analysis and culture. Cancer screening appropriate depending on what the person is presenting with. We know the craft sign for multiple myeloma, the calcium, the renal anemia, the bone pain. We know the what's it called? The the presentation for an individual with blood malignancy of the blood, right? Leukemia, the gum bleeding, the likes, the infection, the way they present. So the presentation is going to guide the kind of cancer screening we are going to do. Then the specific test for some rheumatology conditions we want to do, assay for the HANA, depending SLE, rheumatoid factor, for what's it called, for rheumatoid arthritis, and you want to do your viral culture, serology to rule out the virus, for example, CMV, You might want to culture it or do your serology to make diagnosis for your CMV. Um, that's that. Then imaging, you must obtain a chest X-ray, rule out tuberculosis, histoplasmosis, sarcoidosis. X-ray can help you. You also must do CT of the chest, abdomen, and pelvis to look for occult abscess. Very important. CT of the chest, abdomen, and pelvis can help us rule out the abscess, right? And if we don't find much and we have a very high suspicion, we can do some nuclear imaging, or we do laparoscopy and enter and look at whatever is there. Um, some case by case setting, those organisms that I've listed, Brucella, Coxella, Bartonella, get history of exposure to farm animals, cats, you might consider any one of these and you do your serologic testing to make the diagnosis. So don't forget, rule out infection based on or inflammatory disease, autoimmune disease based on your presentation. That's going to guide what you are going to do in the lab. For the imaging, you must always do your chest X-ray, tuberculosis, sarcoidosis, histoplasmosis, and your CT, abdomen, pelvis, chest. Rule out occult abscess hiding somewhere, right? And treatment is going to depend on what you find, but just make sure you stop unnecessary medication because drug fever is a very common cause. You want to remove catheters, lines, they are sources of infection, right? But people that you don't find anything at the end of your investigation, they have a very good it sounds paradoxical, but they actually have a very good favorable prognosis because it's going to resolve within some few years to months. Um, so so that is that. Then um, moving on to sepsis. So sepsis is something we have talked about already. I've defined it as a clinical entity that is associated with reduction in sorry um we are going to define it as a condition that is associated with organ dysfunction due to dysregulated host response to infection. Sorry, I was thinking um it was sepsis that we defined initially, but I was shocked. So this is sepsis now. So this is just organ dysfunction due to dysregulated host response to infection, meaning that the response should be at a particular level, but in sepsis it's kind of exaggerated, which is now even causing damage beyond the insult, beyond the infectious insult. It's now affecting even the normal organ functioning. Is now dysregulated. So this can be complicated by septic shock because sepsis is just SIRS, any 2/4 of those parameters that we have listed, plus an infection focus. That's sepsis. We can have severe sepsis in which you have SRS, infectious focus, plus any or end organ failure, maybe kidney injury, liver injury, lung injury, severe sepsis. Or it can have progressed to septic shock, in which, in addition to all these things we have said, the person is now having hypotension, in which the mean arterial blood pressure will be less than 65 millimeter of mercury unless you give a vasopressor, or the lactate level will always remain more than 2 millimole, you know, even despite adequate fluid resuscitation. So that is the definition for septic shock. Don't forget those two parameters. We are still going to look at it, and you are going to see signs of organ dysfunction in a setting of an infection. Very, very important. Very, very important. There used to be some clinical tools that we used to assess for septic shock, which is the sequential organ failure assessment. We don't need to worry ourselves about that because most of the signs that they are talking about, we have already mentioned them. So don't forget, septic shock is typically a warm shock. So it's actually with distributive shock. So it's going to be warm, not cold and clammy, right? As in contrast to hypovolemic or cardiogenic shock, where they present with cool, clammy skin. Um, because basically what happens in septic shock is that you have an infection, which is triggering release of inflammatory mediators, cytokines, that causes endothelial injury, right? When there's an endothelial injury, you have extravasation of fluid from the intravascular space into the interstitial space, right? It means there's going to be intravascular volume depletion. So that is going to activate the extrinsic pathway of the coagulation cascade. So there's going to be, activation of the clotting factors, clot formation, which can eventually lead to DIC at the end of the day when it's widespread. So you can see signs of bleeding like petechial rash, ecchymosis, abnormal coagulation parameters like abnormal high NRPT and the likes. So those are the features you see in an individual with septic shock. So what are the laboratory findings that you expect? So we have said it, SIRS plus infection is what sepsis. So um, because of the infection, because of the SIRS part, the systemic inflammatory response, we have said that the white blood cell count there can either be high or be low. It can either be low or high. So it can actually be more than 12,000 or can be less than 4,000. Anyone can be there. Or we can see increase in the band, which is a mature form of the white blood cell. So you can have more than 10% bands, leukopenia less than 4,000, or leukocytosis more than 12,000. All of them are characteristic of sepsis. You can have thrombocytopenia in 50% of cases, particularly those that are compromised by DIC, because you have those activation of the coagulation cascade that is going to mop out the platelet at the end of the day, leading to thrombocytopenia. And we know what happens in septic shock. There is reduced tissue perfusion from the extravasation of fluid, into the tissues. So the fluid is moving into the interstitial space. So they are going to the interstitial space. So they are not going to the capillaries where gaseous exchange will happen. So they are moving into the interstitial space, so limiting tissue perfusion. So you can have end organ damage there, leading to elevated creatinine. Um, when it affects the kidney, elevated liver marker, bilirubin, EST, or the liver is compromised. And of course, elevated lactate, because when the tissue can no longer get oxygen, they start following the path of the anaerobic pathway and lactate starts coming up, right? So when they cause abnormality in the coagulation pathway, you can see elevated INR, you can see prolonged PT, prolonged PPT. So it's very keeping with someone that has, sepsis. Um, hypotension. Hypotension requiring vasopressor to maintain the mean arterial pressure more than 65, or persistently elevated lactate of more than 2 milli equivalent per liter despite fluid resuscitation diagnosed septic shock. So I've emphasized this so many times. So sepsis is just more like a progression. You can have sepsis that goes to severe sepsis when there's endocrine damage, and move to septic shock when you now need, to give vasopressor to raise the blood pressure more than 65, or there is a persistent elevated lactate of this value more than 2 milliequivalent per liter despite adequate fluid resuscitation. That is septic shock. Very easy. So once you see this in your exam question, you are seeing that the mean pressure still gets lower than 65 until they give us pressure or there's persistent elevation of lactate. You know that what you are dealing with septic shock. So how do you treat, how do you investigate? You have done the investigation, you have done the blood work, we have to obtain culture to actually localize the infection. So you can do, depending on whatever presentation the person is having. So if it's a chest infection, you want to do your sputum analysis, you might want to take your blood sample for culture. Sometimes you take CSF, wound, urine, depending. So, and don't forget that you don't wait. So, like, you take your culture and you immediately give antibiotics empirically, broad spectrum, right? Till your culture result is out. Sometimes you might need to do further imaging, like somebody with chest infection, pneumonia. Now you might need to do your CT or your chest X-ray to establish the focus of the infection. So, how do you treat? Don't forget, we have said it already. Aggressive. fluid resuscitation. So you have to give them fluid, a lot of it, crystalloid, you put it, you give antibiotics, broad spectrum, bombard them with that, you resuscitate them virulently, you know, uh, so that you can bring them back. You elevate the mean arterial pressure so that they can be up and doing again. Because by the time you give them fluid, you give them the vasopressors, you are going to reduce vasodilation, you are going to elevate the blood pressure again, and you can achieve adequate organ perfusion. So you have to treat the underlying cause by giving the antibiotics so that you can eliminate the infectious focus. Then, if there's a catheter there, you remove it, you remove infected line, you drain any abscess. If there's a pneumonia, you treat it with the antibiotics, and everybody becomes fine.